Thanks, Laura. Welcome, everybody. I think we'll have more people trickling in as we get started, but I'm going to go ahead and get us moving. We have 3 presentations today, and I want to give everybody their space to share and also leave lots of time for our breakout rooms later on. But I'm Sarah K. Moore. I am one of 3 local liaisons on the state MCH team, and I'll be starting us off and wrapping us up today. If everybody on the call wants to introduce themselves in the chat, you can put your name and agency. It's really nice to see who all is calling in from across the state, who all is joining us today. But today is our MCH combined local learning community. We have regular local learning community spaces for both our state and local teams, but we don't typically have these audiences together. So this is a unique opportunity to bring state and local MCH staff together to learn from one another. We had our first state and local combined local learning community in January of last year. So we're a year later now, and we're doing it again. And last year in January, we focused on our community inclusion MCH strategic anchor. And this time, a year later, we're focusing on our MCH strategic anchor racial equity. So if we continue this pattern, you might expect another one a year from now. But we'll have some space at the end of the meeting today to give feedback on how this model worked and whether or not everybody found use from it. So we hope that you all enjoy having this combined audience today. If you'll go to the next slide, Laura. As everybody continues to hop on, I'm going to go over our participation norms for the day, and you can continue to add your name and agency in the chat and introduce yourself. But we have 3 participation norms for today. So 1, we'll have a lot of people on the call with our state and local combined audiences. So make sure that you're on mute whenever you're not sharing. But there will be several opportunities to speak up and unmute and share. So we encourage you to do that when those opportunities come up. There's a few different ways that you can contribute today. So 1 is raising your hand and unmuting. We'll have a few opportunities for Q&A, and then of course we'll have breakout rooms later, and that'll be a great time to share out. You can also use the chat feature. I'll have Brian monitoring our chat today. Thanks, Reed, for your support. So feel free to add something in the chat, and Reed will keep an eye on that and let me know if something comes up. You can also use reactions throughout the meeting. So we love to use reactions on the state team because we're mostly remote, and it adds a little bit of that human feeling to Zoom and Google Meet. So you should see an opportunity to use reactions at the bottom of your screen. If you don't see it there, you can click on those 3 dots more, and you'll probably see it in that drop-down menu. You can add a heart, clap, encourage our presenters today as they're sharing. It's nice to have that interaction in these virtual spaces. And then I don't think we'll have any polls or Jamboards today, so you can ignore that last bullet point there. But then finally, be present where you can. I know that we probably have a lot of snow days and kids at home today, so if you need to be off camera, totally understand, no worries. But if you're able to be on camera, we love to see faces and have that interaction. And where possible, quiet distractions. So resist the urge to multitask. I get it. I have that same urge all the time, but try and be here if you can. But of course, we understand that things come up. So take care of yourselves. Next slide. So this is our agenda for today. Tara is also going to add our agenda to the chat, and that has our plan for the meeting today, as well as our slides, if you need to go back and reference those at any point. So right now, I'm welcoming everybody. I'll do a little bit of stage setting around our strategic anchors, and then I will introduce our first speaker, our team from Rio Grande County Public Health. We're excited to hear from them today. And then we'll pass it on to Adams County Health Department. And then finally, we'll hear from some of our state team around their work around this strategic anchor. And then after we hear from all 3 of our presenters, we will have breakout rooms. And the breakout rooms are going to be focused on our 3 different presentation topics. So we'll have those presenters join us in the breakout rooms, and we can do any follow-up questions there. And we'll also be able to open it up to more broadly our 3 breakout room topics and continue to learn from each other in those spaces. and that is going to be a choose your own adventure breakout room space. So we'll have facilitators in each space, and as well as our presenters joining specific spaces, but everybody else just kind of gets to pick whatever speaks to them, whatever you want to dive deeper into. And then we'll return from that, share out a little bit, and then we'll wrap up, and I'll share out a meeting eval form for feedback. Next slide, please. So before I introduce our presenters, I want to do a little bit of level setting around our MCH strategic anchors. So like I said, a year ago, we were able to have a space similar to this focus on our community inclusion strategic anchor. And today we're going to have a special focus on our racial equity strategic anchor. The MCH strategic anchors came out of our 2019 MCH needs assessment. So they're coming up on they're coming up on a birthday. So they've been around a while now, and we've learned a lot about them. They were new with our last MCH needs assessment, and we plan to continue them into future years. But MCH and both state and local MCH staff felt strongly in our last needs assessment that they wanted alignment across our 7 MCH priorities, and specifically wanted alignment in how to approach the work across our 7 MCH priorities. And we identified anchors of how we would find this alignment. So our MCH strategic anchors are mechanisms that allow us to remain tethered and mindful across our priority areas, and they also promote a level of shared accountability in the work that we do as MCH teams across the state. And as we enter our next MCH needs assessment right now, we have the opportunity to adjust those MCH priorities, those 7 priorities that we have, but we don't plan to adjust our MCH strategic anchors. So those anchors are going to remain consistent, and they're going to guide us through our work and assessment for this needs assessment, our planning work, and our implementation in the next MCH cycle, as well as our reporting. So today we're going to focus on the MCH racial equity strategic anchor, but we know that we can't do racial equity in a vacuum, and it doesn't stand alone. So our strategic anchors all work together. And I think that you'll see that dynamic relationship between the 3 today in our presentations. So we're going to start out, we're going to focus on racial equity today, but I think that you're going to see a piece of moving upstream and community inclusion throughout our presentations. Next slide. So like I said, focus today is specifically on our racial equity strategic anchor. And as an MCH team, we define racial equity as the condition that would be achieved if one's racial identity no longer predicted how one fares in life. And today we're going to hear from 3 different teams, 2 local agencies and some of our MCH state team on how they anchor their MCH work in racial equity. And they're going to be across the board. We're going to hear about community inclusion, racial equity in data, and racial equity in workforce development, as well as other things. So we're going to get started today with our Rio Grande team, and I'm going to pass it off to them now, and they're going to give us one way of incorporating racial equity work into MCH work. So I'll pass it off to Rio Grande now. So you guys take the wheel.
Okay, and then we did have a slideshow.
Yes, next slide, Laura.
Okay, as a form of introduction, so then, first of all, thanks so much, Sarah Kay, for reaching out to us, and it's a pleasure to be here today. I mean, seeing all the beautiful faces for those who are showing up on the video on the screen, and for those who are listening. We are really glad to be here. We wanted to just showcase a little bit of the work. Because of the time frame, we're just going to give you a little snippets. Just whet your appetite a little bit. And then if you have any question, every question at the end of the little presentation, then we'll dive deeper into it. So for now, my team that are working on the health equity program and in line with the MCH anchors, I have myself. My name is Kolawole Bankole, Dr. Bankole. I'm currently the director of the Rio Grande Public Health Department. And I have my able chief nurse here, Salake, you've been really communicating with her, is Diane Koshak. And on my right, maybe on your left, I have the two health equity specialists. You might want to mention your name.
Dolores Atencio.
And Roberta Marcus.
And for, I don't know if Zoom can actually, get your face. We have
Logan Montoya, I'm the operations manager.
yes. So without further ado, I'm going to pass over the baton to Chief Nurse to get us through the slides.
Thank you, Dr. Bancole.
You're welcome.
Can everybody hear us, I hope? Rio Grande Public Health is a small local public health agency located in the south central part of the state. You can see on the map, we're close to Alamosa, Colorado. So we're almost to New Mexico, and some people consider this little New Mexico, but we serve approximately 13,000 residents. We have 4 administrative staff, 1.25 clinical staff, 1 interim prevention staff, and 2 health equity staff, of which we're going to be talking about this morning. Next slide. Thank you. Let me introduce our health equity specialists. They can share each of their particular focuses with our marginalized populations. Roberta Marquez.
I am the agency interpreter and I am responsible for the Spanish helpline, and my focus is Spanish language intervention.
And Dolores Atencio.
And I work as a case manager for our agency. What I do differently is I'm an advocate for individuals and families, not limited to just Spanish populations, but all vulnerable populations.
Perfect. Thanks so very much, guys. We're so lucky to have not 1, but 2 health equity specialists. Since Roberta and Dolores have been on board, they came in April of 2023. We have made significant inroads here with our marginalized residents. That includes communities of color, women, and low-income communities. As you can see from slide number 2, under our priorities, under access to supports, we collaborated with our local hospital to do a H2A health fair with the agricultural workers that come in the summer. It was a huge success. We're so proud of that. And we'll talk about that more in the question and answer period. We give away free car seats, diapers, cribs, and gun safes to folks in our community. Under the social emotional wellness priority, both our health equity specialists are currently teaching. They have 1 class for families called Strengthening Families Program with 7 weekly sessions. And they have another one, Life Skills Training. It's for 4th graders and it's 15 weekly sessions. That keeps them very busy. And then the last racial equity priority, kind of obvious, but so important, is our interpretation for all the things we do. As you can see, restaurant inspections, etc. And they also operate a Spanish language helpline, which we can discuss further a little down the line and in our question and answer period. We are qualitatively, but nonetheless, observing that these ongoing activities are building much more trust with our special populations in our community. Next slide. We intend to be purposeful with our health equity planning. As you can see from this slide, we're using a spectrum of community engagement model from Rosa Gonzalez. She wrote it in 2019. It's a practical yet visionary resource to help people work through a spectrum of changes with their services. So as you can see on the slide, it's linear. 1 on the left is inform, and then I don't have all of them, but 5 on the right is community ownership. So we are slowly moving through this model. We have achieved proficiency with the inform because we do health fairs, we're doing the advocacy at the individual and family level. We're spending 60% of our time administratively and 40% of our time with promotion. And under consultation, we have become proficient both through our China project, but other things that we have done, we're getting comfortable with that, surveys, etc. And under the involve, we are working that direction and aspiring to get to level 3. We haven't got there yet, and to get to involve, we'll need to get to community advocacy rather than individual and family, and get interactive workshops, etc., with the goal to make 60% administrative effort and 40% community collaboration in the near future. We are so much more empowered and equipped now to reach the next levels of this spectrum model. Our health equity specialists have increased our confidence and expanded our vision of the possible versus the impossible. Next slide. And in just the programmatic conclusion, and we'll hear from Dr. Bencoy in a second about other things. But with each new health equity intervention, we have learned something new about this process. We hadn't had any ability to do this before. So we're learning from ground zero. We plan to assimilate what we learn each time to apply to our next interventions. We remind ourselves that our health equity program is a developmental process, and we can only focus one day at a time. We've got to give it time to succeed, so we can't be in too big of a hurry. And we strive to capitalize on the progress, and someday, pardon me, the slide cut off, but I do have it here. And someday eliminate marginalization through community inclusion, racial justice, and eventually, this is our ultimate goal, community ownership of some of these programs. Thanks so much. And our director, Dr. Wole Bankole, has designed this roadmap with a strong focus on health equity, and his determination made this roadmap a reality. And here he is to explain.
So, thanks, Dan. And with the model that has been presented to you, I wanted to, add one or two things so that, at the end of the day, if you don't remember all the gammas that I say, you remember 2, 3 things. One, our health equity model is based on 2 basic philosophy: genuine community engagement, and 2, language justice spectrum process. Diane did a great job, enumerating that model, going from consult to involvement. There is actually an updated version from CDC that really broke things down into participation, engagement, and ultimately partnership. So, depending on the program that anybody is doing, there is that piece around participation. To what extent do we have the community participate through our outreach to them, through our consulting with them, with the ultimate goal of getting them interested in what we're doing? And also for us, a mutual way, understanding what their plights or their needs are. So that is the first piece. Second piece is really engaging them. And that actually involves, proper communication, opening up the channels of communication for them to be able to access our program, and for us to engage them serially so that they will know how to access that. And once we are fully involved, then collaboration starts really being fleshed out. People talk about participation, collaboration, coordination, but at the level of authentic engagement, you're talking about involving the community and collaborating, which is far beyond just, oh, we want them to participate in an event. The ultimate goal on that spectrum is the partnership. When do we get to the level where we have shared leadership? And at that point in time, there's shared power and responsibility, where you have community members taking some roles in our projects, taking roles and also being involved in community advisory committees, where they have a voice, where they know whatever we're doing about them is from them to them. So that is the basis of our authentic community engagement, which involves the participation, engagement, and ultimately partnership. The second piece that I mentioned is the language justice spectrum. This really was the basis behind our creating the health helpline. It is not a hotline. You cannot call it every 24/7, but it is a helpline. People can call from the community to speak to live people. in their language. In this area, we have a lot of Spanish-speaking community members, a lot of seasonal workers, warehouse operators, and potato farm workers. They don't speak English. So how do we open up the channel? We go through a spectrum, the spectrum of language exclusion, language awareness, language inclusion, and ultimately language justice. It is a process. The language, if I say one or two words on the language exclusion is, it's like the worst case scenario where a language is being well spoken by some marginalized community and we do not provide service to them. That is a language exclusion. And you don't intend to do that, but there's some that come from Guatemala and they don't speak Spanish, but they speak specific Guatemalan language. So at that level, we need to find somebody that provide interpretation or translation for that particular language so that we did not contravene language exclusion. But in most cases, the majority of the language spoken by these folks are Spanish. So we move quickly along that spectrum from language exclusion to language awareness, knowing, and how do you know? There's so many ways to know what are the languages being spoken in the community by actually already having established authentic community engagement. So we move, right now, we are roving between language inclusion and language justice. What do I mean by that? Under language inclusion, it means we have been able to provide the infrastructure, the resource, and then the services to make sure anyone that comes in or at any event that we conduct in all our resources that have been provided either on our website or social services, social media, and through our helpline, we have an improved communication in their language. They can easily call on us, we can easily answer them. So we are including, everything is not done in English. They are both done in English and Spanish language. The language justice level, which is the ultimate level that we want to get to, is to ensure that anyone, if within our country that comes in asking for resources, they will not say because I don't speak English, I cannot access that. We have policy on ground to say that yes, we must provide these services in their language. We have the backing of our authority, the Board of County Commissioners and Board of Health, supporting our policy on ground. We have the policy on ground that supports the enhanced national class standards, meeting all the 15. I mean, aspiring to meet all the 15 standards. So we are moving from that inclusion to the ultimate language justice. So in summary, not to bore you too much with all the rhetorics, our health equity programming borders around having authentic community engagement and ensuring language justice. And in between all of this, the ultimate outcome and goal is to improve access to needed healthcare, break down the barriers, whether structural barriers or cultural uniqueness barriers or challenges, to ensure that access to quality healthcare is enshrined in whatever we do, whether programming, policy, or service delivery. And by extension, we are working ultimately towards one of the social determinants of health as enshrined within Healthy People 2030, which is making sure out of the 5 key major areas, we are focusing on the improving healthcare access to needed care. I will pause there because I don't want to be bringing extraneous information, but yeah, it is very important to have health equity program. It is also important to know what is the basis behind what we're doing in response to the community needs. And it's also, of course, I'm sure I'm going to have a lot of questions around, I'll be asked the questions around how do you build this up and how do you sustain it? But meanwhile, let me pause on that. So back to Diane.
That completes this presentation.
Great. Thank you so much, Dr. Vincoli and Diane and the rest of the Rio Grande team. We're going to have a community inclusion focused breakout room, and we'll have the Rio Grande team join us for that at the end of all of our presentations. So we'll have time there to dive deeper into your presentation and hopefully hear how you started all of those programs and, like you said, how you sustain that work. So excited to dive deeper into that at the end of our presentations today. But thank you so much to your team for joining today. Yeah, thank you. I'll pass it on to the Adams County Health Department team. They're going to share about their work going on in their county and how they anchor their MCH work in our strategic anchor. So I'll pass it on to you, Vicki.
Great. Good morning, everybody. And just as a clarity, this is only a piece of what Adams County is doing, but I wanted to discuss a little bit about racial equity and the public health. I call it a journey that we have been on for the last, going on like 30 years. So go ahead, next slide. All right, so a little bit of history. So Adams County, as everybody knows, was formerly part of the Tri-County Health Department. And a year ago, we began doing work and chose reducing racial inequities as one of our priority areas, and continue some of the work that we've been doing. And so this presentation is just about one little piece of that in the Black health community. And so as part of history, in the 1990s, we started looking at racial inequities, and using data really kind of drove what we were looking at. When Black infant mortality, reducing Black infant mortality became a priority area, we chose that. And so we're just continuing the work. Go ahead, next slide. So foundationally to what the work that we have done, how it really started was really looking at the data. It started with the perinatal periods of risk. If anyone knows what that is, it's a way of looking at the data in your community during the perinatal period. Now, during the City Match conference, it was stated, and I had this aha moment 30 years later, where it said that you cannot separate racism, racial equality from maternal child health, and you really, really can't. If you look at your data, the data is going to show you that story. So for you and your community, that's your first question. What is the data showing us? Is it, are we having displaced people? Is it Native Americans? What is the data showing you where your disparities is? The second foundational is the relationship building. So in part of public health, really, I feel like our role is to work with our communities. And part of that is finding out who is doing the work in the communities. What other work is being done to address? Now, you're probably not the only ones who are noticing this disparity. There are people who are living the disparity. So who's doing that work? Where can you actually join the work that has already actually been doing? So you're going to build the relationship by walking alongside and then sustain that relationship. The thing about doing racial inequity work is walking in the community and being that sustainable ally. You're being authentic. You know, authenticity just means you're being real, you're genuine. It's just not a reactionary action based on something that's going out in the world. It is that genuine, you're showing up. I say the point number 4 for showing up and participate in that, I mean time and money. And you show up and you continue to show up. You show up when it's hard. You show up when it's not the best time, when you're feeling uncomfortable. You continue to show up in the community. You're walking alongside the community. In this case, what I'm meaning is that you're doing with them and not to them. I have some examples from, historically working with Tri-County and with Adams County, where in public health and as a public health nurse, I'm thinking about how do we reduce preterm labor for BIPOC folks. So I have this idea, okay, great, this is this wonderful intervention that we can do. But then when I started working with the community says, no, we really need to have doulas. Now, as a public health nurse and formally working in the hospitals, I'm thinking, why do we need doulas? Listening to the community says we need doulas because doulas are here with us. They speak for us. They are our allies. And so that was an aha moment for me that I never would have thought of if I hadn't been walking alongside. So that's a good example of the journey that you go on when you authentically show up and you say, hey, I'm listening to what it is that you need, not what I think that you need. So that is public health's role to be a part of that, to sit alongside and to find out, put your efforts, build that relationship and sustain those efforts, sustain those relationships. So I'm going to talk about a couple of, go ahead, next slide. I'm going to talk about a couple of partnerships that have been developed over the next year. If you can go to the next slide, Laura, that'd be great. Thank you. All right, so a couple of examples of some partnerships that we built over the years. Now, I recognize that being in Adams County and formerly Tri-County, we have the benefit of a wide metro area, and I don't take that for granted. And I know that some communities don't have that. However, once you start doing some of that background work, there are people out there doing the work. So find those folks, become that ally. And one of them was Children's Hospital. So pre-pandemic, and I'm terrible with dates because everything is pre, during, and post-pandemic in my head these days. So pre-pandemic, Children's Hospital was getting feedback saying that their practices were not respectful of their BIPOC patients. And so Children's Hospital reached out to some community advocates and said, hey, we really want to address this. What do we do? So those community advocates, because Tri-County had been working with reducing racial inequities in Black infant mortality reduction, they reached out to Tri-County and said, hey, would you like to partner? Well, of course we would love to partner because we really feel strongly, because what's happening at Children's is not in a vacuum, right? If we went across the state, I will bet you that some of that feedback is out there too. And so what happened was the Black Health Initiative sat down with community partners. They sat down with community and developed what they called dinner talks. So basically dinner talks were those focus groups, but it wasn't just a focus group, it was dinner. It was sitting down. It was Black women leading Black providers, Black clients, Black patients. I mean, people in the community, they sat down and had a conversation and said, what is going on out there? And that was and you know, they said, listen, we want to take notes. Is that okay? That's fine. To share that with, they came out and said, listen, everything that we already know. We know that sometimes providers do not listen to their BIPOC patients. We know that disparities and racism lives in our systems. And so brought that information back and to the Black Health Initiative. And the Black Health Initiative said, okay, what do we do with this info? And the group itself came out with some ideas. And one of those ideas was that, you know, there's a lot of providers out there. And while we want to work to increase the number of BIPOC providers in the community, we know that's going to take decades. It does. So what do we do in the meantime? One of the things in the meantime was to better give providers in the community, providers who are white, a better understanding of what happens for the Black experience when they go to providers. So they worked with the Anschutz Center, and I'm going to talk about the next slide, so don't go yet, but talk a little bit about what we came out with that. But that was all developed from the Black Health Initiative and that work we did as a community to say, what is it that we need? What's tangible that we can do to combat racism in our system? So another partnership that I've had over the years is with Families Forward Resource Center. And this is a local resource center that sits in the cusp of Denver, Arapahoe, and Adams County. And this is another long-term, long-standing relationship that I've had with a local resource center. And because they hold the Healthy Start HRSA grant. So the Healthy Baby Strong Families program is a program where in public health, I've been able to consult with and talk with them about, hey, how to increase. We do referrals too. They do referrals to us. So it is a strong partnership that has been available for, gosh, going on 20, 30 years. So it's a historical collaboration. And we've also not just with the program, but how do we work together? So they have a community action network where they bring in community folks and they invited public health to the table. So now Adams County, Arapahoe County, Denver County, we are all together at that table. And you're building relationships in these spaces. You're building knowledge of what other folks are doing. This actually increases how many projects that you can do and how many things that you can do for the community with the community so that the community is driving it. So we've done several campaigns over the years for preterm birth prevention, safe sleep, and then now some, and it's everything from safe sleep campaigns to even focusing on policy at the legislative level. So these relationships have been built longstanding and continue to this day. And I continue to serve as a board member too. So that's another way for public health to become involved in the work of the community, to work with the community. That's to become members of their board. They need folks, they need our education, they need our expertise, they need our passion, they need us to show up. All right, go ahead, next slide. So let me expand a little bit on the simulation courses that we continue to partner with. And this is this partnership between Children's Hospital, the Black Health Initiative, and the University of Colorado. So on the Anschutz campus, they have the Center for Advancing Professional Excellence. Like I said, we do have the benefit of being Metro, where we've got some great academic partners, and this is one of them. So in this center, they provide scenarios. The Black Health Initiative created real scenarios. I say created, but they're just reenactments of real scenarios that have happened to Black folks in our healthcare system. And they are blaring examples of racism. And what we do with the CAPE is we bring providers, community advocates in, and we run them through these scenarios. There are 6 of them. So the Black Health Initiative, we provide coaching and prep, getting folks ready for being in these really high emotional, high energy simulations. We provide that coaching during those sessions, and we also provide debriefing so that folks get a deeper understanding. So over the years, we've been able to pull through public health professionals, doctors, neonatologists, you name it, community advocates from Families Forward Resource Center, Children's Hospital providers, and they go through these simulations. And what it does, it provides you this insight into the BIPOC experience. And then you also get that coaching to improve your walk and your practice when you're working with people of color. All right, go ahead and next slide. All right, so my final, hopefully my presentation here, you've got a couple of nuggets, and part of it is data-driven relationship building, sustaining those relationships, and then showing up. Honestly, that is the most important piece of it, is to continue to show up and be there for the community, for what the community needs. Now, I'm going to invite y'all to join us at the workforce development to find out what the rest of the Adams County team is, because I don't want it to seem like this is the only thing Adams County is doing. This is just a small part, and hopefully a couple of nuggets for you to take away when thinking about how to engage your community and what it is that your community needs from us as public health professionals. Well, thank you.
Thanks, Vicki. And Vicki, like she said, will be in our workforce development breakout room. So we'll get to hear from Vicki a little bit more about this work, and we can also open it up to general questions if people want to talk about workforce development and racial equity. There'll be an opportunity to do that. We'll have Vani Tangela joining us for that, and she leads our racial equity workforce development work. So we'll get to hear from both of those teams in that breakout room. I'm gonna pass it on to our next group of presenters. So we'll hear from a few of our state colleagues on their work with racial equity and data. So they're gonna share about the Racial Equity and Data Initiative project that they've been working on. And it's all just now kind of wrapping up. So I'm sure they have a lot to share and are excited to speak about it with you. So I'll pass it on to Vani.
Thanks, Sarah Kate. Hi, everyone. I'm Vani Tangela, and I'm the Racial Equity Specialist. And before we jump into the content, I'm really curious to hear from you all. So why might we want to bring a racial equity lens to the data products that we develop? And feel free to unmute or feel free to put your comments in the chat.
Well, I think it's very, very important to have the racial equities data quantified. Reason being that right from time, how do we even know that there are racial disparities or health disparities without quantifiable data? It's always been said right from time that, you know what, if you do not count us, then we don't matter. And how do you justify the work that has been done? Is by really being able to show black and white the disparities between the different racial entities. And that's why, racial equity in data initiative is very important, highly important, because if we ignore it, then there are so many people that are gonna lose out. That's the only way to justify health equity is to show that there is inequity.
Thank you so much. Absolutely. So this idea of if you don't count us, we don't matter, certainly. And yeah, we're going to lose that. And I love all the other comments in the chat. Mary, disaggregation of data is important to understand how race contributes to disparities. Absolutely. Christina, as not to misinterpret data, to ensure data can move to action to impact the entire population and not just the white population. Absolutely. So to understand disparities in outcomes, inclusion, representations. Cece, racial disparities in MCH are huge and can't be ignored. And Liz, sometimes that state alone, sometimes the state alone quantitative data might paint inaccurate pictures that reinforce stereotypes and do not lead to effective solutions. Y'all are spot on. So that all of those comments and just responses, I think, further reinforce why we might want to consider racial equity in data products. And then if we go to the next slide, I'll just share some of our whys. And this was in relation to, oh, I think it might be, you might have to press several times. Go ahead and just press through all the bullets, Laura, thank you. So some of the context is the MCH state team develops data briefs for each of the priorities. And typically when we have created these data products, it does a great job of highlighting the inequities across populations. So it really paints the picture of, hey, these inequities exist. And then we really realized from just the data brief itself that although we have a better understanding of the inequities, we really don't tie it to the larger picture of why, right? Why do these inequities exist in the first place? It didn't just like show up out of thin air. It didn't, it's not created in a vacuum. So some of our whys to create a supplemental one-pager to provide some of that historical context was to help our state teams' knowledge increase, particularly around the historical and structural context. We also wanted to increase the different priority coordinators' knowledge of other priority structural and historical context and how that shows up. This again, Sarah Kay highlighted this. None of the anchors work in isolation, right? Which is also demonstrated by Rio Grande and Adams' restatement of its community inclusion, its racial equity, it's moving upstream. So being able to bring that moving upstream lens when we talk about data, we're not just saying, hey, we see, low rates of whatever, let's say breastfeeding in the Black population without providing the context, right? To be able to say we're seeing low rates of breastfeeding in the Black population because of these historical and structural factors. And that moves us to a moving upstream frame than just saying, these inequities exist. And Liz said this in the chat, we want to recognize that there's all types of data. So of course, quantitative data is really powerful and it doesn't sometimes paint the full picture. So how can we supplement that with storytelling? How can we supplement that with other forms of qualitative data to paint a more accurate picture? And finally, we wanted to do something different, right? So this was an opportunity where the state team could have said, we've always done data briefs this way, why change it? But we pushed against that, right? So we noticed this observation that this important information was missing. And this was really a credit to all of the priority coordinators who were willing to try something different. And so those were kind of our why as to the Racial Equity in Data Initiative. And we'll go to the next slide. So that's the why. In terms of how we did that was, so for each of the data briefs for the priority coordinators, again, were really willing and they were charged with creating a supplemental one-pager and to connect it to a historical or structural factors that ties directly to their priority. And I'll show examples of what that looks like in the next few slides. And then so they developed the one-pager. We were really, again, looking to frame things from that systemic understanding of how past inequities and past histories are shaping current inequities. So why did we do this? What's the so what? I'll share, I think it's on the next slide, what each of the priorities uplifted in the one-pagers. Laura, if you could go to the next one. So for the priority of positive child and youth development, some of the historical structural factors that were uplifted were the historical trauma that's experienced by Black families and how that leads to an impact in breastfeeding rates. We also address the systemic barriers, the inadequate support or lack of culturally responsive care. Vicki had mentioned this idea of like, yeah, when we were in community, they mentioned doulas and she had this other idea. So how do we create culturally responsive care for BIPOC folks and other marginalized communities? This was also our attempt to highlight specific policies, often state sanctioned and federal government sanctioned racist policies, and how that's created these ripple effects, right? So for the positive child and youth development priority, they highlighted the Homestead Act of 1862, the GI Bill, et cetera. For built environment, they focused on the housing policies, similar to including redlining and also racially restrictive covenants and what that's meant for being able to generate wealth over time and access to home ownership. And then in access to support, they also highlighted the health wealth gradient, and then also the lack of opportunities to economic opportunities and how that ties to private insurance or lack of access to private insurance. We also uplifted the healthcare workforce shortage and how providers often don't necessarily reflect the demographics of the people served. And then of course, this idea of the historical mistrust of the medical system, and then being able to reinforce that with specific examples. So those were the three priorities. And then if we go to the next slide, I'll continue to share some more. In pro-social connection, Lauren, I think you're in this call, so I might flag you real quick to speak about that. The facts of Brown versus Board of Education and the impact on educational workforce diversity, right? Often when we think about policies, we will uplift some of the positives. And of course, there were positives to it. And there were also some unintended consequences of Brown versus Board of Education. And so it had a direct impact on the pipeline and what that meant for the educational workforce. Lauren, are you on this call?
I'm on.
Okay,
Yeah,
could you
everyone.
speak about that? Yeah.
Yes. Let me see. Oh, sorry, my camera's not on. So let me see if I can get my camera on. Say hi, everyone. Yeah, I think one of the data points that came in the data brief was about like trusted adults and about like young people and their experience within the school setting and leading to health. And so we have some data around like bullying and trusted adults. And so one thing we know is that our educator workforce or school staff don't typically match the students' demographics. And so noticing and understanding that that has an impact of how students feel belonging and connected to school. And so wanting to say, okay, why is that? Why is there maybe a shortage of a diversity in our educator workforce, and really looking back at some major policies. And so when we think about Brown versus Board of Education, it did amazing things around the civil rights movement to really think about that we can't have separate but equal. And at the same time, it actually led to a lot of firing of Black teachers. And so then that influences where we see the demographics of teachers today. And so it was this huge thing that happened that was a very good policy, and then had really negative impacts to the teacher workforce. And so that continues to influence how students are interacting with teachers and school staff today. So just wanted to highlight why we see some of those things and dive a little bit deeper into what the data is telling us and what the experiences of students might be. So really quick, I'm happy to talk more about it in the breakout session, but that was something that we found and wrote a little bit about for that data brief.
Thanks, Lauren. And then for our other priorities of economic mobility, they really highlighted the racial wealth gap. And again, the design of welfare and benefits programs are often also problematic, right? So sometimes when we have certain requirements, they perpetuate the same inequities that we're trying to eliminate. And they also highlighted mistrust in the government, particularly coupled with language barriers. Going back to Ria Grand's presentation around how we want to strive towards language justice, that if we have folks that are requesting services, that we're able to provide it in their language, right? And so that was another highlight. And social emotional well-being, they also highlighted the historical mistrust in the healthcare system, and the disproportionate impacts of children and families and being targeted in the child welfare and court systems, and big tobacco's push of menthol into Black communities. We are kind of in the final stages of formatting and finalizing these one-pagers, but we will supplement the one-pagers alongside the data brief so that we can have a more complete, at least not, maybe not a full, more complete, it might not be fully complete, but more complete picture of how the structural and historical factors contribute and still impact the priorities that we're all working on at the state team. What else? Let's see. I think that's all I had. I do want to leave with this question on the next slide and would love to hear again from you all. You can either unmute or come into the chat, but what is the cost of not, and Laura, feel free to go to the next slide. Thank you, Laura. So what's the cost when we leave out the historical and structural context? Thanks, Reed, for putting into the chat. I'll give folks a minute to think through, and feel free to unmute and or drop it into the chat. Liz, do you want to come off mute and share more? And if you don't want to, that's okay. But blaming impacted populations for the disparities. Okay. Responsibility gets placed on the people most impacted. Absolutely. Trust that history won't repeat itself. Yeah. But others. Missing the boat. The history is integrated into the problem. And Adelina, we make assumptions about why disparities exist, never addressing the root cause. Yeah. So when we think about racial equities or racial inequities, right, it ties to what are the foundational aspects, what are the root causes, again, connecting to that moving upstream approach, complicity in racism, perpetuating systems that disadvantage people of color. Yeah. So if we don't really understand or appreciate the root causes, how can we solve for them in our current day? So absolutely, y'all are spot on. I do want to be mindful of time. So for all the other breakout rooms, I'll be joining the Racial Equity and Workforce Development Group. Feel free to join. Understanding how inequities become embedded in the systems policy. Yes, absolutely, Sylvia. And no problem, Liz, no need to come off mute. All right, I'll turn it over to Sarah Kay.
Thanks, Bonnie. And Bonnie also included some resources in the slides. So when you go, if you want to go back and reference the slides, those will be linked there. And Bonnie, if you want to
I forgot about the, sorry, I forgot about the resource. I'll just go through it real quick.
Yeah, totally.
Thank you. I think it's the next slide. Cool. So for anybody that's on this call, workforce requests, we're here for you. So even if you aren't even sure what you are wanting to think about or to work on, it could be just an initial consult, right? So if you fill out the request form, we'll meet with you. Oftentimes it's a quick 30-minute chat to better understand what's happening. This is of no cost. We could also support you in coming out and potentially doing workshops or other kind of engagement, visioning. So there's a ton of resources and opportunities, but feel free to reach out via the request form. And then I also highlighted 3 different resource formats. There's an article on why we might want to apply a racial equity lens, and how that supports building thriving communities. It's also attached to that webinar, if that's the format that you prefer. So how do you center racial equity throughout the data lifecycle? So that really goes from like planning to the collection of data to the analysis of data. So the full data cycle to the dissemination. And then if you want want to go really deep, there's a cool toolkit, again, that goes through the entire data lifecycle, and the different considerations you might want to think as it relates to race equity. So check those out. And then thanks, Tara, for dropping in the request form. We're always here for you, so feel free to reach out. Even if it's a exploration call, we're happy to meet with any of you.
Thanks, Bonnie. And the slide deck again is linked in the agenda. So if you want to go back and reference after this call, you can click through any of those links, and definitely encourage, if you have a need, to reach out to the workforce development team, because they're a bunch of super passionate and impressive people and can definitely help your team grow. But thanks to all of our presenters. I think you all did a great job of really demonstrating how all the strategic anchors work together, and you can't do racial equity without community inclusion and moving upstream, and also just how important that racial equity strategic anchor is across all of our MCH priorities. So I really appreciate all of you taking the time to put together presentations and share. Laura, if you want to go to the next slide, we are going to transition to breakout rooms now. So each of our presentations will have a corresponding breakout room. There'll be 3 options. We'll have racial equity and data, and that's going to focus on what Bonnie just shared. Lauren is going to join that group and facilitate, and she has experience putting together one of those ready documents. I think we'll also have Reed, who is part of our data workforce team at the state, and I think Jody is also going to join, and Jody is one of our MCH evaluators. So I'll have lots of data experts on there to talk through any questions you might have about that presentation, or just more broadly, racial equity and data. Then we'll have our workforce development, racial equity and workforce development call. Vicki is going to join that along with Bonnie, and they can answer more questions about Vicki's presentation, or open it up more generally to racial equity and workforce development. And then finally, we're going to have racial equity and community inclusion. So we're going to have our Rio Grande team join that call. They can share more about the work that they're doing with racial equity and community inclusion, and we can also learn from others on the call around that work. So it's choose your own adventure. We'll have a few people specifically go to rooms to help facilitate and answer questions about our presentations, but everybody else, you are welcome to join whatever breakout room speaks to you, or anything that you want to follow up on. So I'll have Laura open up those rooms.
How long are the rooms? Or how much time do we give them?
Oh, let me double check that. Thanks for asking, Laura. We'll come back at 11:55 to wrap up. So we'll have a little over 30 minutes in the rooms, 35 minutes. And the 3 rooms are named. So you should see it pop up on your screen, the 3 names of the rooms. If you don't see it, you can check those 3 dots for more, and navigate to breakout rooms and join from there. Laura, if you don't mind hanging on the main room just to help people if they have any trouble getting into rooms, I'm going to hop into our community inclusion room and help facilitate there.
Sure.
Okay, thanks so much. So if you have questions, ask Laura and she can help you navigate to whichever breakout room you'd like to join. Thanks, everybody. Got cut off. We were in the middle of some rich conversations in our breakout room, but if anybody has follow-up questions, I'm sure I can get the contact information of our speakers to any of you if it's not included in the slides. So feel free to jot down any questions you might still have in your mind, and I can definitely connect you if that information isn't included in our follow-up materials. We're gonna start wrapping up. Laura, if you don't mind sharing the slides again. We are going to do a fun, Lauren shared this share out strategy with me because we only have 5 minutes, and I know that there was a lot of rich conversation, but we want to find some way to capture the conversations we had in our breakout room. So we're going to share out waterfall slides, or waterfall share out. So the way you do it is open the chat and you'll type in what your big takeaway from your breakout room was, but don't hit send until I say go. We're all going to hit send at the same time. So we're going to kind of get to see everything come together at once, and we'll share out the chat with the rest of the meeting materials. So you'll get to read through and hear a little bit about what happened in the other breakout rooms, and it'll just be a cool way to see what everybody was able to take away. So I'm going to give everybody probably like 45 seconds, a minute to think about what their big takeaway was from their breakout room, but don't hit send yet. We'll all hit send together. So take some time to add it into the chat, and I'll let you know when to push the enter button. Okay, I'll hit send in 10 seconds. So I'm gonna count you down. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Okay, everybody hit enter if you're ready. Lots here. I'm going to read a little bit out. My takeaway is that we have work to do, but there are great people and resources we can tap into for questions and advice when we begin. Stay open to multiple solutions. Community members may have ways of doing things that are different from how you would do them. Being in the community and with the community is essential. Engagement is so much more effective when we meet them where they are and not expect them to come to us. In diverse communities, outreach should be specific to the populations we hope to reach. I have ideas to incorporate to our existing work in a frontier county as well as new ideas. There is not one right way to do work. And there's a lot more there. So we'll share this out, and you can reflect on it. We'll share this along with the slides in our agenda and our recording. If you have team members that weren't able to be here today, feel free to share that with them. We'll post it on our website as well. But I want to say thank you again to our presenters and to everybody for being engaged and sharing in those breakout rooms. I hope that this is encouraging to work that you already have ongoing, and that some people are walking away with new ideas and new ways to do things, as well as hopefully some new connections. Bonnie shared those resources from the state in the slides, and you'll have access to those. But if you made any connections with a local public health agency today that you want to get contact info for and weren't able to get the chance to, feel free to reach out to your local liaison. So either me, Reed, or Tara, and we can definitely facilitate those connections. But before we leave, I'm going to share a meeting eval link, or Tara's going to share a meeting eval link for us in the chat. And you'll have an opportunity to share how this went for you today, what you walked away with. If you're still needing support in a certain area, you can share that, and how you liked the state and local combined model, how that felt for everybody. So feel free to give us some feedback there. And if that's in the chat, it'll also be linked in the slides, and shared and follow up if you don't have the chance to do it now. But thank you all for your time today. You're free to go. I hope everybody stays warm. But thanks for your engagement today, and thanks to our presenters.
So thank you so much, everyone, for your time.